Good evening, colleagues. Hope you're as excited as I am to participate today. We welcome you to an Association for Acute Cardiovascular Care webinar on diagnostic strategies in patients with acute hypotension. My name is Jason Katz. I'm an associate professor in cardiology at Duke University, and I'm excited to be joined with some excellent speakers who will follow me in a second. I have the pleasure of introducing and moderating a session led by Dr. Francesca Renon from Monaldi Hospital, Sergio Leonardi from the University of Pavia, and Sean Van Diepen from the University of Alberta. We hope that you'll enjoy this webinar. We hope it'll be informative and help with your care of the patient with acute hypotension. After watching this webinar, our goal is for you to be able to identify a variety of diagnostic strategies applicable for patients with acute arterial systemic hypotension, to develop strategies to help you distinguish life-threatening from non-life-threatening causes of acute hypotension, and to be able to rapidly identify treatment options and strategies based on presumptive diagnoses. We'll have clinical case presentations as well as didactic lectures. The session, it's important to emphasize, however, should be interactive, and we strongly encourage you to actively participate by sending questions our way and comments our way that we can get to at any time during the webinar through our chat feature. For the best learning experience, we also invite you to participate in online assessment sessions in the form of multiple choice questions or MCQs that will be submitted during the presentations. With that being said, I'll now hand it over and introduce Dr. Francesca Renon, who will be giving a clinical case presentation on diagnostic strategies in a patient with acute hypotension. Dr. Renon.
Hello, good afternoon, everyone. So as anticipated, I will introduce the session with a clinical case. And these are my disclosures I have known. So I present a case of a 79-year-old gentleman with multiple cardiovascular risk factors, type 2 diabetes mellitus, hypertension, and dyslipidemia. On his past medical history, a dental operation 20 years ago, a chronic coronary syndrome with the previous revascularization of the LAD, FRF or mildly reduced heart failure with a previously known ejection fraction of 40 to 45% and a severe secondary mitral regurgitation. We get to know this patient because he enters a cardiac ICU over hospital for monitoring after a percutaneous correction of the mitral regurgitation with the mitral clip system. He got one clip implanted with a good echocardiographic result in the cath lab. When he enters the ICU, he is well and hemodynamically stable. He has just got a bit of blood oozing from the arterial sheath, which was left in the left common femoral artery, and we removed it after correction of anticoagulation with protamine. After 15 minutes approximately, the nurses called for a hypotension of this patient. The blood pressure was 80/40 millimeters of mercury, and the patient was slightly symptomatic for dizziness. He got an arterial line for invasive blood pressure measurements, so we flashed the line and repeated the measurements, which confirmed the blood pressure. So here comes my first multiple choice question for you. Which of these is not a common possible cause of acute hypertension after a cardiac interventional procedure? 1, errors in blood pressure measurement. 2, cardiac tamponade. 3, an acute failure of the procedure with a complication, for example, a dislodgement of an implanted valve or device or coronary artery complications. 4, a significant hemorrhage, or 5, a septic shock. So I have 30 seconds, I guess, here to vote.
That's great. Yes. So everyone, if you can weigh in, you have about 15 seconds left. And I'll share the results with our speakers and with the participants. 5 more seconds. So which of these is not a common possible cause of acute hypotension? By and large, the audience suggested that septic shock was unlikely to be an acute cause of hypotension after a cardiac interventional procedure. 88% of respondents.
Okay, I'm happy with that because that was our answer too. So generally speaking, patients undergoing interventional procedures are elective patients or semi-elective patients, usually well controlled from the infectional point of view. So sepsis or septic shock are not common causes of hypertension immediately after a procedure. And we performed a point-of-care ultrasonography in this patient. First, we excluded a cardiac tamponade. We checked the left ventricular function, which was compatible with the last known ejection fraction. The clip was well positioned and was negligible mitral regurgitation. The mitral inflow pattern showed dynamic response with respiratory variation, which altogether with the other findings was compatible with hypovolemia. So we performed fluid administration with 500 mL of crystalloids and the pressure normalized. After 15 minutes approximately, the blood pressure got down again, 75 over 40 millimeters of mercury, and again the patient was slightly symptomatic for dizziness. So we performed a second fluid bolus, another 500 mL of Rinda with blood pressure normalization. But again, after 20 minutes, hypertension was observed. So here comes my second multiple choice question. Which of these tests would you use as last assessment of an acute hypotension in this patient? Rapid but accurate physical examination, ultrasonography, a blood gas analysis, right heart catheterization, or a contrast-enhanced computed tomography. And you have 30 seconds to vote.
Great. This is a great case so far, Francesca. It looks like the patient stabilizes and then gets hypotensive and stabilizes and get hypotensive, and that probably leads some people to surmise what might be going on. We have 10 seconds left. Francesca, we're going to have a mix of answers here, I think. So which of these tests would you use as last assessment of acute hypotension in this patient? The top answer is right heart catheterization with 38%, but about 31% suggested ultrasonography and another 23% contrast-enhanced CT. Okay, so our answer was right heart catheterization. Actually, the first 3 tests are quite rapid and they can give you an assessment of the context of the hypertension, physical examination just to see the patient is not bleeding, outside bleeding, or physical signs of a specific cause of hypertension. The ultrasonography, I already showed you an example of point-of-care ultrasonography, so a very rapid and easy test you can perform to rapidly exclude acute and severe causes of hypertension. And the contrast-enhanced CT is quite frequently used in this context because it is rapid and it can give you information about hemorrhagic complications, for example, in patients undergoing interventional procedures. So we reviewed the labs the patient had at the entrance of the ICU, and we noted a slight reduction of the hemoglobin and of the hematocrit. And we then performed a central venous blood gas analysis, which confirmed the continuing decreasing of the hemoglobin
The lactate was normal, but we have an initial reduction of the central venous saturation of oxygen, which was 49%, indicating beginning maybe of a shock. We reviewed the chest X-ray the patient had performed after the procedure, which didn't give any specific sign, but something that captured our attention was a slight increase of the curvature of the trachea confronted with the pre-procedural chest X-ray. And we returned to the point of care ultrasonography. In this case, we were in the subcostal view, in a slightly modified subcostal view, and we were pointed at the gastric level. And we found this image, which was not so easy to interpret at that point. So we decided to perform a contrast-enhanced CT to confirm this data and also to exclude hemorrhagic complication given the reduction of the hemoglobin and the data of hypovolemia. And I have to remind you that the first hypotensive episode had occurred after 15 minutes from the removal of arterial sheath in the femoral artery. This is a still image of the CT scan we performed, which showed a marked gastric ectasia with hydroaeric level that you can see here. And in the contrast-enhanced phases, an endoluminal contrast enhancement flash was noted, likely coming from the lesser curvature of the stomach, compatible with an acute bleeding. And no significant vascular complication was observed at the femoral axis level. We talked with the interventional echocardiographist who assisted the procedure, and he said the entire mitral clip procedure was guided by TOE in the transgastric view because of a bad transesophageal window. We tried to resuscitate further the patient with fluids and blood and pressors. The patient got intubated and we started an endoscopic procedure in emergency. The data was of an acute bleeding from a gastric ulcer with a probable esophageal wall dissection. So the most probable cause of bleeding in this patient was due to the heating of a transesophageal probe in a transgastric window that heated previously unknown gastric ulcer that began to bleed. Unfortunately, the endoscopic procedure failed in controlling the acute bleeding, and our patient died before reaching the operating room for surgical treatment. So this is a bit sad ending of my clinical case.
Thanks so much. You had me fooled. I thought the patient was bleeding for sure, but that was not the source of bleeding that I anticipated. It's good that you really walked everyone through the sort of the differential. I think probably most people thought about bleeding, but certainly an unusual and unfortunate
side, yes.
Yeah, so incredible. Well, thanks so much, Dr. Renon. Next, we have Dr. Sergio Leonardi, who will discuss with us rational decision-making in the management of acute hypotension and really speak to us, much as Francesca presented. Sergio will talk about the importance of having a systematic approach to hypotension management.
Thank you, Jason, for the introduction. And then I'm Sergio Leonardi. As you said, I'm a professor, associate professor of cardiology here in Pavia, and I work in our cardiac intensive care unit in San Matteo Hospital. And I had exactly the same impression as you had about how difficult are these cases. And I think points very well how it is heterogeneous, the presentation of patient with hypotension, and especially for patient with bleeding, we may have a lot of type of source of bleeding. So the goal for this presentation, of my presentation, what I will try to do in the next 10 to 12 minutes, it is to try to structure a path for the management of patient with an acute hypotension and an unclear diagnosis. I hope it worked perfect. I have no disclosure as well. And then as I said, will try to identify and define acute arterial systemic hypotension. I think an important point it is that we should always remember is to distinguish causes that are maybe related to that, as the one that Francesca Renon just illustrated from non-life-threatening cause, so the priority, and then to rapidly identify treatment strategy based on presumed diagnosis. Now, let's start very simply from the definition. So systemic arterial hypotension has been defined by different target, but it is usually defined as in clinical practice of most clinical trial, as Sean Van Diepen will later discuss in more detail, as an SBP lower than 19 millimeter of mercury, or a mean arterial blood pressure below 60 millimeter of mercury. Acute hypotension, it is a dynamic concept, so it requires a time frame and usually a development of hypotension within 30-60 minutes, and that's an important concept to always remember, that a patient that is going well and has a low blood pressure should be distinguished from a patient with an acute hypotension. And as we know, but it's important, I think, to remind, shock, it is a step forward, is defined by evidence of hypoperfusion, which we can do clinically in a variety of ways. One of the quickest is by evidence of hypoperfusion by lactate on blood gas analysis, by confusion, cold clammy skin, and as we know, we have other indicators that require a little bit more time, such as oliguria, that usually, but not always, concur with acute hypertension. As I'm pretty sure you know very well, there has been this very important classification by Sky of cardiogenic shock that has been recently, actually this year, updated with the goal of provide not only a classification that gives you an idea of the severity of the presentation, but it's really focused on what we should try to think about that help us thinking about the trajectory of the patient and try to think very proactively, where are we going if we don't do a prompt diagnosis or we don't do a prompt treatment where we do have a diagnosis. And as you can see in this later iteration of the SKY classification, we have patient at risk 4, these are patient broadly defined. Patient in B, that are patient with hemodynamic instability, including hypotension and tachycardia, or different signs that point us toward the possibility of shock, but we don't have evidence of hypoperfusion which define stage C. So a patient in shock starts stage C, and then we have the 2 stages that we want to avoid: patient stage D and E, who are deteriorating, and patient who are in a refractory shock that has of course the worst prognosis, with this useful concept of having cardiac arrest as a modifier. Cardiac arrest, severe cardiac arrest, so cardiac arrest with concern of an oxygen brake injury in this last version that can at all time change rapidly our prognosis because of course bring our cardiac output to 0. It is useful, this work that has I think Sean involved about the utility of considering a patient, the differentiation of hypotension and hypoperfusion. As you can see, the hospital mortality for a patient with isolated hypotension is lower than patient with isolated hypoperfusion. So this is a classification that provides some rationale for using stage B and stage C. And now we can move to what are the potentially life-threatening causes that we should always consider. Now, it is something that has, of course, there are several causes, so it's important to try to think. I will try to make this as short as possible, but I think these in red are the codes that we should always systematically remember, because are the codes that are most usually and most commonly involved. And even within each single cause, as in the cries that we just described, we may have a lot of presentations, such as the hemorrhage we just discussed. Now, what is the approach? I will try to be very practical and very concise if I can. So a preliminary, very important step, it is always when you are on call, when you are called by a patient, by your nurse in your ward, in your intensive care unit for a suspected acute hypotension, to confirm that. So it is important that when you have an hypotension, if it is by especially non-invasive management, to look at the patient first. If it is okay, it is possible but unlikely he has an acute hypotension. If you have an invasive monitoring, check the curve shake, check the proper zeroing. If you have a non-invasive, all the proper sizing of the cuff. So if the patient is doing well, confirm. It is important to confirm to avoid starting pressor and other medication that can harm the patient. So always remember this. Then if you confirm, and assuming you confirm your patient has hypertension, the most important step, it is to focus on some few elements that can help you try to try to funnel down the diagnostic possibility. Now, it is important, especially for patients with a long chart, to go to key diagnosis and key comorbidity, and especially inquire for circumstances surrounding the event. So it's important to ask, what is the diagnosis this patient is entering for, and what is the key comorbidity? It is extremely important, the second bullet point, because sometimes you may have patients that just, change the IV line, that may have a bolus of a vasodilator. So it's very important to understand what's happening, because this may be involved, and it is in a lot of situations. To know the pharmacological history, including the actual medication, because of course all the medication should be reviewed and changed in this patient immediately as a first step. And it is important, again, to understand associated symptoms such as chest pain or dyspnea that may help you pointing toward the direction and give you a perception of the severity of the clinical presentation. Patients that are in severe distress usually require a rapid diagnosis, of course. Now, let's move to the diagnostic testing that may help us to try to get to diagnosis. So the diagnostic tests that are most useful and can help you reach a diagnosis are, in the vast majority of cases, the ECG. Always remember that tachycardia is the physiological response to hypertension. So if you have bradycardia, usually you already have the diagnosis. The patient may have a conduction disturb. A patient can have a severe vasovagal reaction, for example, such as patient where you are taking down your femoral sheath, and the patient has severe pain, you have an acute hypotension. Sometimes you may have an important hypotension. If you have concomitant bradycardia, this is not likely an hemorrhagic shock. It's an important vasovagal reaction, so you can wait or get atropine if that persists. Blood gas analysis, of course, it is very important. There are many values that can help you, as Francesca was saying, of course, the hemoglobin and others, but usually it is one of the most important is the lactate that can help you. It's not, of course, the only value, but can help you confirm the diagnosis of hypoperfusion, i.e. shock. But the key diagnostic test to identify, I think, cardiovascular life-threatening condition, if you are unable to get the diagnosis with its first two tests, it is, I would say, certainly echocardiography. It is a rapid echocardiography. It is a focused echocardiography. I'm not an expert echocardiographer, but usually it is the tool that help me most of the time where I have to make a diagnosis. So the third bullet point is to perform a diagnosis. So I will start with my first multiple choice question to ask you, after you are called for a patient who are acute development of hypotension without a lot of other element, and you see this echo, what is your first suspicion just on the basis of this two projection on the echo that you are doing? So I will start with my, oops, sorry. Yeah, so I wanted to, okay. This is the beautiful of the reality, because I went to the next slide, but then I'm pretty sure you have imagined what is the diagnosis. Anyhow, I will ask you, what do you suspect in this patient? You have 30 seconds to vote, and then the option or a complication of an ACS, an acute pulmonary embolism, an acute hypovolemia, a cardiac tamponade, or none of the above.
Great. We'll have 30 seconds to answer. Sergio, while they're answering this question, those are really great echo images, and not always so easy to get on the emergency department patient. If you had your choice of sort of where to get, quick echo images, well, what would you suggest to the participants?
You mean which projection?
Yes, which projection?
Yes. Sure. Usually, I mean, the most helpful, and especially, as you know, in patients who are at risk of cardiac arrest or other, is usually what I use personally. It's a subcostal view. Just a quick comment, usually remember that you don't have incredibly elevated pulmonary pressure in this phase, because in acute pulmonary embolism, in a patient that has does not have chronic problem, usually is unable to generate a pressure more than 50, 60 millimeter of mercury. The classification, remember, for high-risk pulmonary embolism, so a patient that require either fibrinolysis or a mechanical solution that are now emerging. As you know, it is cardiac arrest. That's pretty straightforward, not very common. Shock, obstructive shock, that is the definition that we use, and evidence of an organ hypoperfusion, as we say. But always remember that persistent hypotension, it is per se an indication if it lasts longer than 15 minutes per guideline, and it is not caused by arrhythmia, such as atrial fibrillation, which is very common in this setting, and in this patient that are preload dependent may reduce pressure, hypovolemia, or sepsis. So this third point, I think, is the one that you should look very carefully, not only for the diagnosis, but also for the concomitant condition that can point toward the high risk and therefore your treatment strategy. There are many, now this is a pretty detailed slides. Again, I will not go in detail because we already discussed what is the mechanism. I'm pretty sure you know what are the echo finding and the relative sparing of the apical segment, which is, in my experience, one of the most common signs. It is a pretty common and useful sign. But it is something that you should always consider, that in hemodynamically unstable patient, if you don't have a right ventricular overload, you can virtually exclude this as a cause. So it's very useful. Also, this is very clearly indicated by the guideline, while an equivocal sign of right ventricular pressure overload can be considered for an emergency hypoperfusion, and you don't need a CT angiography in this case, okay? Case number 2. So again, we do have an acute hypotension, and this is the mitral inflow velocity that you can see on the right side. I will show you this for another 5 seconds and then ask you exactly the same question. What do you suspect? A complication of an acute coronary syndrome, an acute pulmonary embolism, an acute hypovolemia?
So I think people are all over this one. I think too. But it is, I mean, it is, oh, sorry, probably you have now to present it. No. We got 5 more seconds, though. So 79% suggest it was cardiac tamponade, Sergio.
Very good. So we have 4 out of 5 that say that it's cardiac tamponade. I do agree as well. As I was trying to say earlier, Jason, I think it's important. I like cases where even that may seem simple for us, but it's a case that we see in practice, and so, not all the time the diagnosis is so straightforward, even if you have the right images. Now, it is cardiac tamponade, and because, as you probably, I can trust. Component of not only the right atrium, which is the first chamber that usually tamponates, so essentially collapse, and then, but here you have sign also of diastolic collapse of the right ventricle, that is, of course, most consistent with a cardiac tamponade. Here you have the mitral inflow velocity that have a large variability, and if you have a variability that is usually more than 25-30%, this is strongly suggestive for ventricular interdependence, and this is essentially well delineated in a long document, that is this one, that is probably most useful to have a very broad context than being operational, and it's also no option that you have in a patient with cardiac tamponade. And I think it is pretty helpful. Now we can move quickly to the third case. This is the patient that came in for chest pain for 3 days, and then this is the presentation that we had in our cardiac intensive care unit. I will ask the same question now. Oh, sorry. No, something went wrong. So what do you suspect in this case? A complication of an ACS, an acute pulmonary embolism, an acute hypovolemia, and a cardiac tamponade, or none of the above?
You have 30 seconds to enter or register.
As well, so that takes take out some of the thrilling, but I think this is a pretty straightforward in this case, because we decided also to put an arrow to show what it of course was in the echo finding.
For sure, and people delaying their presentations to the hospital.
That's very true.
The vote results are in, and 75% suggested that this was a complication of an acute coronary syndrome.
Okay, so we still have a majority, but not everyone, so 3 out of 4. And it is indeed, as most of us were suspecting, a mechanical complication. That's a do have relatively small infarction and evidence of hyperdynamic left ventricle and, of course, centric mitral regurgitation. I saw, Jason, many times a patient that came in so quickly to the cath lab that where this diagnosis was missed. Actually, as you mentioned, it is not a very common diagnosis, but I think it is useful to think that in a patient who has an important dyspnea, and patient with an acute pulmonary edema, that you are really refractory and that is not going well, and you see a mismatch with the infarction the patient had, to do an echo that does not delay the angiography, especially patient had symptoms for a few days, but is extremely important because it really can change the treatment that is, of course, surgical instead of percutaneous, as in this case may even complicate the surgery. And In this case, of course, check in patient with hypotension in acute coronary syndrome, first check V-systolic function. Pump failure, we know, is the most important cause of hemodynamic instability, cardiogenic shock in acute myocardial infarction, but not the only one. If you see a normal or hyperdynamic left ventricle in shock-ME patients, think very quickly to a mechanical complication, even if you cannot do a sophisticated and precise diagnosis. And also consider that a possibility it is an acute right ventricular infarction that is another cause of hypotension that we should routinely consider in patients with inferior MI of RCA territory, especially if we have a proximal. So in conclusion, acute hypotension is common in critically ill patients, may be associated with a variety of life-threatening conditions that require comprehensive and systematic diagnostic approach that I try to funnel down. It is essential to diagnose life-threatening and potentially treatable condition, and therefore to know and to remember what they are. And I think that overall in this setting, echocardiography is probably one of our best friends. Thank you.
Thank you so much, Sergio. Now we'll move on to Dr. Sean Van Diepen from the University of Alberta, who will discuss with us narrowing the differential relationships to treatment associated with the patient presenting with acute hypotension. Dr. Van Diepen.
Jason, thank you for the introduction, and thank you to the ACDC for the opportunity to chat today. But before I get started, I'm just trying to advance my slides here. I don't seem to have control. Oh, there we go. It came through. All right, before I get started, I don't have any conflicts of interest. And my objectives today in the next 10 minutes are to provide a framework to rapidly narrow your differential, something you can use in the emergency room or in the CICU, and to link these narrow differentials to the safety of early therapeutic interventions when you may not have all the information. And then finally, when you're failing, what are some strategies to identify the cause? All right, so when I ask trainees to define shock, they immediately go to blood pressure. And here's one from New England Journal, the SOAP trial. You know, the MAP has to be this and the SBP this after fluid, unless the CVP, don't remember this stuff, guys, or the wedges at a certain level with evidence of tissue hyperperfusion. And not to pick on the sepsis researchers, here's the cardiovascular researchers. Look at these definitions within the major trials. They include blood pressure. Now, in all of the trials I've mentioned, these definitions are very important for the internal validity of the trial. But whether it's sepsis or cardiogenic shock, it's a bedside definition that results in biochemical evidence of hypoperfusion. The problem with the academic definitions I've described is that you can have shock with relatively normal blood pressures. Absolute CVPs and wedge pressures are really problematic, and shock states are actually very common. So from a practical definition, shock is reduced oxygen delivery or consumption. And I'll talk a little bit at the end. It could also be a result from impaired oxygen utilization. I'll mention that a little bit towards the end of the talk. Now, the classic Hinshaw and Cox definition, you know, these four causes of shock really stand true today. But you need a way to narrow them down. How can you put these into bins or figure out what's more likely? Well, you know, after your ABCs, don't not do CPR, don't not address the airway, but then try and narrow it down. Are they cold and mottled, or are they warm and vasodilated? Are they wet or dry? Wet, you know, do they have chronic edema? Is the JVP elevated? You know, put your stethoscope on their lungs. Is there pulmonary edema? You may even have an X-ray at that point, and you can bin them into these four categories. And how this is helpful, it's not perfect, but this is at the bedside that you can do in 30 to 60 seconds. You can get a sense of where they stand. If they are cold, it's possible that they have a low cardiac index. If they're warm, they could have an inappropriately normal or decreased SVRI. And how these correlate is you can get some ideas about what the underlying cause is. The easy one is vasodilatory. If they're warm and dry, you can go through your sepsis, anaphylactic, neuro, liver, and endocrine definitions. If they're cold and wet, obstructive and cardiogenic shock is by far the most common. We heard from Francesca at the beginning. If they're cold and dry, hemorrhagic, hypovolemic are by far the most common. And if they're warm and wet, the least common, they can be fluid resuscitated septic shock or, perhaps a mixed shock state. Beyond the 10 seconds, Dr. Leonardi has really gone through this in detail. So Sergio, I won't repeat what you talked about, the importance of physical exam, echo, and imaging. But this will help once you put them in a bin, then go through his assessment to try and get them to a more focused cause. The challenge, and the big challenge, is you've got a few chameleons, guys, and there are certain definitions or certain causes that can really span this quadrant. The most classic cardiogenic shock is still cold and wet, but there is euvolemic cardiogenic shock, and these are patients classically acute decompensated heart failure who remain Lasix responsive that you've probably seen before. There's vasodilatory cardiogenic shock, where the infarct can result in a cytokine storm, just like a SIRS, and cause inappropriate vasodilation. And of course, toxidromes can present in many different ways, depending on the type of drug you take. For instance, wet and cold, or cardiovascular audience, a beta blocker overdose. Cold and dry, if you've seen a Lasix overdose, very difficult to manage, but they can present cold and dry. And, warm and dry, a calcium channel blocker overdose like amlodipine can very much present this way. Endocrine causes, they can span different ones, whether it's a theo or hypothyroidism. Once the heart gets involved, they can go from cold and dry to cold and wet and become a myxedema coma. Whereas if you're in hypothyroidism, when the heart starts to fail, you can be warm and wet at the same time. So depending on the phase, they can present differently. And lastly, don't forget the possibility of mixed shock states. So they can, depending on the second form of shock, they can present in different ways. And here's some examples of mixed shock. If you're wet and cold, myxedema coma or a theo. Cold and dry, you can have heart failure with hypovolemia from overdiuresis. And warm and wet, think of the classic classes of purulent tamponade. You can be inflamed and obstructive at the same time. So once you've identified the first one, think of that second one. And here's why it's important. Here's a Spanish sepsis cohort. These are just patients who presented with sepsis. But when you have high cardiovascular SOFA scores with cardiovascular involvement, you have just under threefold odds of mortality. So identifying early not only relates to treatment, it relates to prognosis. Here's from the C3TN, the first one of the first analyses of over 20 primarily tertiary CICUs in North America. And what you can see here is cardiogenic shock, still the most classic form of shock in your CICUs, but a full 1 in 5 have mixed shock, which is sort of the historical domain of general medical ICUs. And at least the point estimates, and it's important here that the group with the highest point estimate for in-hospital mortality is in the mixed shock cohort. All right, so how does this relate to therapy? Well, once you put them into bins, you have to think carefully about, fluids is usually the fastest thing you can give to try and resuscitate somebody. So normal saline, for instance, if they're cold and dry, you can usually get away with giving them fluid. Now you're going to say, well, there's cardiogenic and euvolemic phenotype in there. As long as it's small volumes in a setting, and in my experience, you don't know where they are on the Frank-Starling curve. So smaller volumes in the cardiogenic component can be helpful. And of course, if they're bleeding, blood might be preferable. When they're warm and dilated, I think fluids is an easy go. You have to be a bit more thoughtful if they're warm and wet. How wet are they, and are they likely going to respond to additional fluids? And if there's a cardiac component, you have to be a little bit more careful if they're not ventilated. And if they're cold and wet, well, I think cardiogenic is probably a solid no. But if you're in tamponade, for instance, fluids are a good choice. So you have to think a bit more carefully and delve down into things. What about relationships to therapies? I think for most forms of shock, norepinephrine is the first go-to agent. And for most cases, yes, if you're warm and wet, go to it, with the exception of anaphylactic shock, which is quite uncommon in our practices. But if you're warm and wet and you're dilated, norepinephrine is pretty safe. If you have mixed shock states, I'll say norepinephrine is my first line almost always, and it's fairly safe to use. Now, if you're cold and dry, you have to think a bit more carefully. Well, maybe they need more fluid if they're dehydrated. And if you're in a euvolemic shock state from SCI B to C, acute decompensated heart failure, that's not that sick, well, maybe an inotrope in a monitored setting is better than norepinephrine. And if you're wet and cold, well, sure, if you have obstructive shock, I think that's a great idea. But if you have cardiogenic shock, the SOAP trial aside, I want you to think carefully that you can do a lot of harm or actually least beneficence, using norepinephrine. Think about HOCM, for instance, identifying HOCM and this goes back to Sergio's comment about using echo. In those cases, you'd want to use a negative inotrope and phenylephrine and vaso. Mitral stenosis, severe mitral stenosis with atrial fibrillation, the same. Atrial regurgitation, you want to maintain a higher heart rate for shorter diastolic filling time. So something with more chronotropy would be preferable. So put some thought into the cause of cardiogenic shock, because you may want to tailor your therapy accordingly. All right. So what if that quick approach fails? What if you've gone through it and you're still struggling? Here's my brief approach to it, is to think outside the box. What are some other causes? And I couldn't decide which joke to put in here. So I put a different joke in here saying that, you have to take it from a different angle and look at it from other causes. And here are my 3 things. 1, consider normal tensive shock states if you're failing. And then go through your lactic acidosis differential here. I won't go through this in detail. I can never keep this in my head. I've had to know it for exams, but I know where to look. Causes of increased lactate production, including D-lactic acidosis or seizures, things of that nature, decreased utilization. And then there's some unknown causes like metformin toxicity. And then finally, go through your histotoxin differential. This is something that you probably should keep in your head if you're a general intensivist, but the warning signs for cyanide toxicity and methylglobinemia. And I think Francesca, you brought that up earlier. Blood gases with part of your initial diagnosis. They can be quite helpful in narrowing that definition. So my take-home messages, ladies and gentlemen: 1, have a systemic approach to narrowing the differential to a few items, and then go through Sergio's approach into doing a deep dive into what the cause is. Maintain a differential and consider alternative differentials, using the outliers when you're failing. And norepinephrine is often a safe first-line vasopressor, but it can worsen a shock in very select phenotypes. So thank you for your attention.
Sean, that was fantastic. And that concludes the didactic lectures. We have about 10 minutes left. People are more than welcome to submit questions online, and we'll tackle those. But why don't I take a stab at tackling what I thought, based on your guys' discussions, were some of the most sort of critical points, okay? And then feel free to weigh in or correct me or tell me that I'm absolutely wrong and wasn't paying sufficient attention to the discussions. But here's what I would suggest are perhaps key messages. One is, and I think this is true for anything in medicine, look at the patient, right? No matter what, if you hear that the patient is hypotensive, your first strategy and goal should be to go to the bedside, right? To leave your computers where we spend most of the day, to leave your call bed and go see the patient. And then when it comes to rapid evaluation, probably the first step, and I think Francesca and Sergio emphasized these, is confirmation. Confirm that indeed the patient is hypotensive. That may be repeating a non-invasive blood pressure analysis. That may be placing an arterial line to confirm that the patient has systemic arterial hypotension. But confirmation is key before you apply any number of therapies to the patient that may or may not cause deleterious side effects and consequences. Everyone here, Francesca, Sergio, Sean, emphasized the key and the importance of having a systematic, rational approach. And I think, everyone that is in their training that's on this call will certainly cultivate that rational approach over time. that will, seeing more and more patients will help them to sort of cultivate an approach. But having a systematic approach to the identification and management of the hypotensive patient is critical. I think, several of you emphasized this, and I think it was most illustrative in Francesca's talk, where she emphasized the importance of serial assessment, right? She didn't just give a bolus of fluids to the patient and walk away. She gave a bolus of fluids to the patient, saw that the patient responded hemodynamically, but then also saw that the patient then deteriorated hemodynamically and became hypotensive once again. So just because you restore some normal homeostasis or relatively normal hemodynamics initially doesn't mean you should stop following the patient. So the serial assessment, be that serial examination of the patient, serial history from the patient, serial analysis of invasive and non-invasive hemodynamics, serial echo, what have you. But this is there's a need to sort of serially assess the patient. I think Sergio emphasized this, and we are obviously a cardiocentric group of presenters at this time, but this is important, I think, in any intensive care medicine. Echo or ultrasonography, particularly point of care ultrasound, can absolutely be your friend in helping differentiate potential diagnoses. And then, and I'll ask you to weigh in, particularly Sean, about this. It's not always straightforward. There's lots of overlap in shock conditions. There's lots of overlap in causes of acute hypotension. As you emphasize, mixed shock is common, and we should always have our antenna up thinking about mixed shock. But sometimes you just have to aggregate and accumulate the available information, come up with what you think is the best diagnosis, and an initial therapeutic strategy, and just try it, right? You apply that initial therapeutic strategy, and you're prepared for a good response and a not so good response. But sometimes you have to just apply the therapy both as a therapeutic approach and as ultimately a diagnostic approach, and then that's where the serial monitoring comes in. So we don't have any questions here online, so I'll open it up to the speakers to maybe hit on some of those messages or add your own messages at this point.
Well, maybe Jason, I'll go first. You just mentioned my name. I'll pick up on what you said at the end. Is that what I often tell my trainees is that they should never fall in love with their management plan, and that really that relates to the difference between a good intensive care doctor, or any doctor for that matter, is someone who is willing to consider alternative diagnosis or management when the first one doesn't go well. I think we all get things right sometimes, and we all get things wrong the first go. But maintaining that open differential and the willingness to reassess things when they're not going as expected is the key to improving outcomes.
Yeah, I totally agree. What I liked a lot about what Sean's presentation, which was more in general intensive presentation for someone who is not probably only as myself in a cardiac intensive care unit, it is that you may have really a lot of causes, as you really showed us. And then, of course, it is sometimes very hard. It is very hard to remember all of them. But what I think it is important from Francesca's case, I think illustrate, and I will be happy to know her opinion as well, it is that this was the patient that the biology, the patient usually tell us the diagnosis in different ways. This was clearly a patient that despite the bolus were going down again all the time. And clearly there was something then where the suspicion of bleeding was probably high in all of us, but the location was unusual. So absolutely be open-minded, consider all the possibility, and use your mistakes, as you said, Sean, to learn what are, because sometimes if you do something, may help you understand the real diagnosis, or what we say in Europe, exadjuvantivis. So that is, use your response to therapy to help you getting new data, even, and try to follow that path. And if it's wrong, you can understand from that. So it is absolutely important to do what you said. And I totally agree about what Jason said was a fantastic sum up, I think. Thank you.
Francesca, any other thoughts? We're almost at the end of our session, but we'd love to hear from you if you had any additional thoughts.
Okay, I know I would share what you said. I agree with everything, and yeah, actually, in our case, the particular response to the footballers was ex-adjuvant, was confirmation of our initial hypothesis. So we obviously can think about causes of hypertension or causes of every other issue that we may have to treat in our unit, thinking about probability. So patients undergoing cardiac interventions, they usually have hypertension due to some causes. So we can think about probability. We can use initial measurements, initial measures of correction, and then see the response to these measures. And we also have examinations that are quite used routinely, like a CT scan in those kinds of patients, of TAVI patients, for example, to exclude vascular access complications when you use large bore sheath for vascular access. But then you have to think in parallel, using your mind and using different examinations. For example, in the case, the finding of this strange image, which later revealed to be the stomach of the patient, using a different oriented costal windows, was a way of think outside the usual examinations. And in this context, the capacity of using the ultrasound, not only cardiac ultrasound in point of care mode, but also lung ultrasound, abdominal ultrasound, vascular ultrasound. It's a very, very useful tool to utilize. It's rapid. It has usually a short curvature of or apprentice, so it's a very useful tool.
That's great. Well, we're almost out of time here. I think the take-home points really are rapid but systematic. That's the way we need to approach these patients with acute hypotension. Probably the quote of the day is, don't fall in love with your treatment plan. I'll add, don't think you know everything about arterial hypotension. I learned a lot today. I hope the participants did as well. I want to thank Drs. Renon, Leonardi, and Van Diepen for their excellent presentations. I want to thank you all for letting me moderate this, and especially to the participants for their attention and participation. So thank you so much. We hope you have a great night.
Thank you.
Thank you.
Thank you. Thank you.